have the pleasure to introduce Luis Lopez Ibor. He's going to do a presentation. Okay, Luis, it's all yours.
Okay, how are you? Thank you very much. Good afternoon, good evening, good morning. Okay, I like to present some tips and tricks of the complex, just a minute, compartir. No, I like. My presentation is this. Just a minute. Compartir, ¿cómo hago? John.
Yeah, okay. You're going to make the PowerPoint bigger?
Just a minute.
Yeah. There you go.
It's okay?
Yes, now it's good.
Okay, I present only 2 or 3 cases with the complex bigger aneurysm, medium size of giant of the middle cerebral artery. It's a challenger of the endovascular team. Why? Because some cases have feeders born in the sac. You are the superior branch and inferior branch of the middle cerebral artery, AP view, lateral view. And this is the 3D reconstruction. You are the branch, come to the sac. It's difficult because when you embolize this, you are at risk to close this branch. But this is the neck. And in my opinion, some case, this image is not totally true. This is the 3D reconstruction. Probably the neck is only this point to this point. But when you embolize this type of aneurysm, you need every time to use the balloon remodeling. And then, if you want, you complete or change with stenting, standard stenting, 1 or 2. This is a case. But where is the question? The question is when you navigate with the material and with the catheter on the guide wire, you change the geometry every time. You change the geometry of the anatomy, of the normal anatomy. And when you remove the catheter or guide wire, you change the anatomy, and it's possible you have a complication. Okay, this is the aneurysm. This is AP view and lateral view. This is the road mapping. And to start, I navigate inside the sac. This is a balloon remodeling. I put 1 balloon in this branch from this to here, a second balloon in the second branch. This is a distal balloon inflated, but you are a loop inside the sac. When you inflate it, the balloon, slowly you remove the catheter, the guide wire, to have this good position. And then you replace the balloon close to the neck. You start from some coils, and look, this is the guide wire, this is the balloon in the neck, this is the coiling. I put a second catheter and balloon in the inferior branch of the middle cerebral artery, double balloon to double remodeling. But this is a picture to example of balloon. When you put the coil and you deflate the balloon, the coils go out to the neck. This is a danger, no? You are very be careful to this situation. This is the reason when sometimes I use the stenting. When you are the morphological change of the coiling or the packing, you need to complete with the stenting. The aneurysm, I put one micro catheter, distal part. I put the stenting, Neuroform or Atlas stent. I remove the coils, put the stent in the superior branch. Here the stent in the superior branch, AP view. You have the stent. Also, I put a secondary stent in the inferior branch. Now you are the neck reconstruction. But be careful also, because when you remove the guide wire, it's possible you are a kinking of the stent and close the branch. This is the reason when I put the stent, I wait 30 minutes to check if you are thrombus in the vessel. This is the double stent here, at same up here. Okay, the situation is, I think it's okay. And then I put the coils. It's a good, but you are a remnant neck here. This remnant, in my opinion, is better to wait 1 week or 2 weeks, because if you push more coil here, you are a mass effect in the stent and you are a progressive thrombus. This is the remnant neck. And I decide, wait, and in the second time, embolize this. But this is a control. And now I look this perforant branch. I put the coil in. Every time I check, don't have a kinking. And this is total fucking of aneurysm. And this is the final control and asymptomatic evolution. This is the reason when I put one stent where we place, every time, this is another aneurysm, you are kinking in stenosis in this part of the terminal ACA. When place the stent, you are more possibilities you kinking. Only with this stent, The control is okay. I put some coils. I have a good flow in both branch E1 and M2. But the patient developed paresthesia 6 hours later. The reason is a kinking. I come the patient another time, second time to the angio suite, of angioplasty to open the cells to go into this part. I open the cell in this point. This is the evolution. But this is another example of the middle cerebral aneurysm, oblique projection, AP, another oblique projection, some branch proximal to the neck. This is the change of the anatomy or geometry of the anatomy when you put a balloon or a stent. Look, this is the normal position of the vessel. When you put the balloon, you change the anatomy. And when the key point is you choose the best branch to put the stent or balloon remodeling to place the coils. When you remove the material, you don't have a geometrical anatomy. This is the control, a good resolution, and replace the geometry of the coiling of the middle cerebral artery. This is the final control. Late phase to look, you are very good flow. In the basilar is another example to look the kinking every time you are kinking. Be careful with the kinking of the stent. Okay. This is the example when I cross one or second stent. After to place the stent, you need to balloon remodeling inside to open the cell in place. After embolization, the coiling, some coil here. Replace a final result. Okay. The second example, final example, is the complication of intrasaccular device, web. This is a middle cerebral aneurysm with large neck, AP view, lateral view, and rupture aneurysm. There are some morphological change in the fundus, but it's not rupture. I talked with the proctor of the company of the web, and this is a good case. Okay, I think if you like, it's a good case. I'm going, but I think it's not a very good case because the direction of the neck is different to the intrasaccular device. This is the aneurysm before implant the web. The guide catheter going very high from here and then from this part. Look. When I have a risk of rupture, every time I place one balloon remodeling protected before, because if you are a rupture, you help with this balloon. when I put the web, the aneurysm is ruptured. And 4 minutes later, this is the web. This is the web. This is the catheter with balloon. This is the catheter, distal catheter with the web. This is a rupture. 5 minutes. Compression, manual compression of carotid. Reverse the heparin initiation, anticoagulation. And then I put inflate the balloon, I wait a little bit and stop the bleeding, but I have a risk to or rebleeding or change of the place, the web inside. I decide to put one stent to protect the vessel. This is the web. And this is the final result. You are some neck remnant. This is the CT scan in angio suite. Look, the web is in subarachnoidal. This is in the middle cerebral artery. This is in the subarachnoidal. This is the bleeding. Reconstruction, you are the neuroform of the stent. You are the web. The patient don't have a good evolution, 24 hours, stand up, no problem. But I don't like to use the endosaccular device to treat the aneurysm. I think is, in my opinion, is I don't use. I prefer to discuss with the neurosurgeon, your clipping, your bypass, whatever you want, or reconstruction, but this material is dangerous. And every time you have possibility to remnant neck, I don't like this device. Okay, so you have any comment or any question? Thank you.
I can speak.
Okay, thank you, Louis. Okay, any comments, questions?
May I
Yeah, go ahead, Eula.
comment? Louis, thank you for. Can you hear me?
Yes,
Yeah,
we can hear you.
Louis, thank you for sharing these 3 cases. So I have to say that if you travel from Madrid to Barcelona, you can take the straight way, but you can go also around the world and to come from Madrid to Barcelona, or in China you can travel from Beijing to Shanghai straight way, but you can go around the world and come from Beijing to Shanghai. So I think in these cases, which were simple, broad-based aneurysms, the straight way is to do clipping, not to try to push something there or innocent vessels. You are doing extremely complicated. Of course, it is wonderful to push something inside and to occlude the sac, but the right way is to put a clip there. So these things which are pushed inside the arteries, they are extremely expensive. A clip is $300. So this is, I cannot understand, for example, in China, many of these aneurysms are treated by endovascular means. Of course, you can speak with the patients and tell that it is dangerous to open the head and so on. It depends how you speak and spread the information. But completely simple thing is that these broad-based middle cerebral artery aneurysms are best treated by direct clipping until something new is coming. So I think whatever is published here in WeChat or LinkedIn, successful cases, so it is not the general knowledge. This is my strong saying. I like you, Luis, because you are telling about the difficulties also, and this is not always heard by the endovascular information spread. This was my comment.
Thank you. Thank you. No, yes. Of course, I think it's important to present the difficult case or if you want complication.
But these were simple aneurysms for direct surgery. They were simple aneurysms, straightforward cases.
I agree.
No one can say that these MC aneurysms are difficult to clip. No one can say if it is in well-trained hands by a microsurgeon, it is 1-2 hours operation. And here you push something many hours, and then you are afraid one day that something happens, what is pushed inside the vessels, arteries, or aneurysm. I think you should think, of course, the patients listen to you if you say that
yes,
we have to open the head, it is dangerous, we can push something there inside. Okay, this is how you inform the patients and how the general information is going around. But simple truth is that the clip in these MC aneurysms is the best treatment. My teacher, Professor Pieles, told that we continue to enjoy the perfect clip around the base of these deadly sacs. And this is extremely good sentence. It should remain in the mind of the neurosurgical world. So if something is good and perfect, it should not be replaced. Is my thing after doing so many. So you can push stents for $200 or euros inside the artery, but it's not good.
Yes, but I started in 92.
I'm speaking about MC aneurysms now.
Yes.
About...
No, MCA, only MCA. But I started in 92 to treat the MCA aneurysm with coiling, and in 2000 with the stent or before. The different situation. See, on rupture aneurysm, the patient, I talk with the patient, but I don't like open the brain. I free a neurosurgeon. Okay, I understand. The problem is not the method of the treatment. The problem is the neurosurgeon or the endovascular surgeon, and you choose the best to the patient. I agree with you. The rupture aneurysm is different situation. The different main point of the surgery is possible to treat it in acute phase. I have more than 4,000 aneurysms treated by myself. More than 50% or more is in acute phase. And in acute phase is before 24 hours for me. At the beginning, in emergency, I don't like to ambulance in emergency. I like to wait 6 hours or 10 hours because it's different to treat the patient at 3 o'clock in the morning or 8 o'clock in the morning. It's different. The important is the team. See, I have a good neurosurgeon in my team or in my hospital. Of course, the middle cerebral artery is not easy to surgery to endovascular. Totally agree. Also in the old patient, because you are the atrophia, cortical atrophia, you are more easy for neurosurgery. It's difficult to endovascular because you are the loops, you are the arteriosclerosis, you are the, it's complicated. For me, endovascular is good, sorry, to the acute phase of or difficult aneurysms to surgery. But the surgery is depend of the neurosurgeon, not the surgery. See, I have a good neurosurgeon in my hospital, of course. Go. Treat the patient. Why not? Is my comment.
Thank you very much, Louis, and we'll probably see you next week.
Next week, whatever you want. Thank you very much.
Yeah. Thank you, Louis. Thank you.